about how to achieve a better future in the face of the then unprecedented challenges of the early 1960s. Key to our research then, as today, is a unique approach, a unique focus in trying to solve problems deemed unsolvable by the so-called experts. We have done this repeatedly over the past five decades by understanding policy in a broad perspective, culling insights through integrated research that draws on economics and the power of markets, human ingenuity through science, technology, and innovation, all of this against a backdrop of shifting demography and geostrategy. Central to our research has been work on health policy and a belief, as we've seen over the last 50 years, that technology and human choice are central to lengthening lifespans and reducing the cost of medical care. Our healthcare research today is anchored by Senior Fellow Tevi Troy, the former Deputy Secretary of the Department of Health and Human Services. Tevi will moderate the question and answer period shortly. Now, as to our speaker, I can think of no better speaker in the U.S. Senate to examine how to solve the looming crisis of Medicare, which poses such a broad fiscal threat to our country, than Senator Tom Coburn of Oklahoma. The senator is a rare bird here in Washington. He is widely known for speaking his mind, for his genuine independence, for standing up to both the left and the right on critical issues, and of course for his fierce opposition to waste in federal spending, and a profound concern about long-term budget liabilities, a concern we share here at Hudson Institute. The senator was known for leading the fight against earmarks, and his Back in Black bill this summer, which he introduced, called for an unprecedented $9 trillion in spending cuts. Dr. Coburn is a physician by training and practiced up until this year. A businessman by background, he was elected to the Senate in 2004 after 3 terms in the House of Representatives. He currently serves with distinction as a member of the Senate committees on the Judiciary, where he's the only non-lawyer, on Homeland Security and Government Affairs, and on Finance. And in response to the current Medicare crisis, the senator has introduced the Seniors' Choice Act, which aims to reduce costs through a variety of means, including competitive bidding for benefits and increasing cost sharing by wealthy Americans. The senator will speak briefly. He has then graciously agreed to take questions after his remarks, and you can follow us on Twitter and tweet live at Hudson Institute using the hashtag #SeniorsChoice. And so he's graciously agreed to take questions both from the audience here and at home. And ladies and gentlemen, without any further ado, let me say what a great honor it is for me to introduce Senator Tom Coburn and to turn the podium over to him.
Well, good morning. We probably don't have anything in front of our nation that is more critical both for our national security but also for our future, even if it had no national security implication, than our budget. And nobody denies the fact that the greatest component of that is the federal obligations through health care. Ronald Reagan, long before he was president, identified a time for choosing. And quite frankly, that's where we are again today in our nation. The choice is between trusting Americans versus trusting an elite group in Washington to make decisions for us. And with my independence comes my desire to be able to make choices for me and make decisions for me. I often travel throughout Oklahoma, and one of the things is yesterday I turned 64 years of age. So I understand the aging process, and I understand the insecurity that comes with aging as your health has bumps in the road and you fail. And I understand how important health care is to seniors. But I also understand one other aspect of seniors' lives that's just as important, and that's their progeny, their grandchildren. And we are now faced as a nation with making critical choices over a very short period of time. Some have said that's not a short period of time, but I would tell you we have to make the choices within the next 2 to 3 years if our children and grandchildren are to survive in an America as we know it. The key crisis is, how do we strengthen Medicare? How do we provide quality health care for seniors that our grandchildren can afford? If you look at the numbers today, the average couple puts in less than $130,000 in their lifetime in Medicare taxes. And on average, they take out $350,000. If you combine that with the demographic shifts that are happening in terms of my age group, the baby boomers, and what we're seeing coming into Medicare, you can readily see that's an impossibility. And you hear the calls that we can't change Medicare. And the fact is we will change Medicare. We will change Medicare significantly, but that does not mean we will change quality health care for seniors. And the reason that we'll change Medicare is because the world's financial community won't loan us the money to pay for it the way it is today. It is a fiscal impossibility for us to be able to borrow at the level that will be required to sustain Medicare as it is today. So we have a choice in front of us, and we can follow what has been put forward in what I choose to call Obamacare, where we have a top-down elite bureaucracy that ultimately rations Medicare, or we can use what we've used in every other aspect of our society, save education and health care, and that's the good choices of market forces allocating scarce resources to drive efficiency and quality. Tackling Medicare in election year is what is known as taboo in Washington. I think that's exactly the time to tackle it, to build a consensus of what the real facts are about Medicare, the fact that it is absolutely unsustainable, that close to 15% of everything that we spend on Medicare is fraud or mispayment, and that we've not addressed that. That would buy Medicare 5 or 7, 10 years of life just to address the fraud. We can't even get a FAST Act, which has 37 bipartisan co-sponsors in the Senate, on the floor of the Senate, that will actually address it. What are our options? Our options are to choose between market forces and Washington elite. And just by example, can we trust consumer choice to allocate a scarce resource? Can we be involved? That doesn't mean that a 95-year-old senile individual has to make those choices, but it does mean somebody can help them make those choices. And can we allocate through consumer choice more consistent, more economical, more efficient utilization of the resources that our children are going to provide for health care for us? I would tell you that trusting elites in Washington is exactly how we're going to end up with the Independent Payment Advisory Board. And nobody should defend other than the fact that that is nothing but a pure rationing board. The whole goal is to look at a cap and say, how do we reduce payments within that cap to be able to control the cost of Medicare? That's why it has a cap on it. Peter Orszag, who actually identified and planned the Independent Payment Advisory Board, had this to say: we need to jettison the Civics 101 fairy tale about representative democracy and instead begin to build a new set of rules and institutions. The problem with such commissions is that they reduce the power of elected officials and therefore make our government somewhat less accountable. I want you to hear that statement. We don't need democracy to decide how to handle health care. We need elites in Washington to decide how to handle health. I would put forward to you that that's the destruction of freedom in our country. And when we have the elite position that we know better, and that the greatest country in the world that has achieved more efficiency, a greater standard of living, and has done it through consumer choice and market forces, and that we need to abandon representative democracy as we do that, is the height of the choice that Reagan identified. What are we proposing? Senator Burr and I introduced in the Seniors Choice Act is an idea to create competition through premium support. If you're on Medicare, you like it the way it is, you can stay there. The only problem is traditional Medicare is going to have to compete with the market. So we allow you, through a premium support, to buy whatever you want to buy. And we both age and health adjust that and income adjust that, so that you have the ability to make decisions about your health care, your financial situation, with the aid of a system that will get you better care with less dollars. And the assumption behind this, and this is a recognizable fact, it's actually been confirmed by 4 separate independent studies. 1 out of $3 that we spend in healthcare today helps no one. It doesn't prevent disease, and it doesn't help cure disease. If, in fact, America would solve that problem, that 1 out of $3, then our healthcare burden would be much less, and our health outcome would be much better. How do we do that? And we do that through the forces of competition and consumer choice. Beginning in 2016, we require Medicare to compete directly with private plans. We modeled this somewhat after Medicare Part D. We allow each senior to get a fixed government stipend, which is actuarially equivalent to what they would be receiving today. But we set up a competitive model within the private insurance plans, controlled by a consumer protection board, to make sure those plans are not cherry picking, make sure they're what they're supposed to be. And then we make Medicare compete with that. So what we do is we put the forces of competitiveness back into the system, which we do not have today. Ask yourself for a minute why we have an acute shortage of primary care doctors today in this country. Why do we have that? Because you have a price-fixing bureaucracy that has undervalued the value of primary care, internist, family practice, etc., and they've underpaid it. So why do you have 1 in 50 doctors who graduate from medical school in this country? Only 1 in 50 go into primary care. Because for the investment that they've seen, they're responding to market forces. Well, if we want more primary care doctors, what has to happen? You have to create a market incentive for them to go there. And the option against that is that the government will tell you what kind of position you'll be. The elite position is we'll mandate only so many positions in all these other areas, so we force people into primary care. So the whole goal behind the Seniors Choice Act is to set up, both through increased recognition of our aging. So we would start in 2016 by slowly advancing the age of eligibility for Medicare. We would start by 2016 a premium support competitive model, which is adjusted both for income and both on both ends of it. If you're on the very low end of income, you get an actual boot up in your premium support. And of the 60,000 people who have adjusted gross income in this country who are collecting Medicare today, you would get less help. In other words, you'd pay the full cost of on Medicare Part B. We also would have an impact and direct in terms of supplemental policies. Most people don't realize that people on Medicare today who buy a supplemental policy consume 23% more Medicare dollars with exactly the same health outcome. So we combine the A and B deductible together. And we create a new maximum exposure for all seniors. We create a maximum exposure so that you know you'll have here's the limit of which you will never spend any of your additional dollars on. We limit low deductible Medicare supplemental policy, so that we can do one thing that's most important in healthcare. And I want to give one final comment on that, and as an example. When you have skin in the game, I don't care what it is, whether it's healthcare, buying a car, buying groceries, whatever it is, if there's a connection with an extraction from your pocketbook, you're a better consumer. When it's not, when there is no connection, we see what we're seeing in healthcare today, that there's no differential increase in cost for overconsumption. And we do know through lots of studies that we have overutilization in large areas in Medicare. And the reason that we have overutilization in large areas, it doesn't really have that much to do with patients as it has to do with providers. So we would put that in. And the example I use, I've had the good fortune to take care of a ton of Amish families. We have this large section in Oklahoma that has a large Amish community. And they don't have health insurance. They are the best purchasers of health care I know anywhere in the world. They want to know what something costs before they buy it. They want to know why I have to have it. And if I have to have it, where can I buy it most cheaply? They negotiate deals on pricing. If I pay you in advance, do I get a discount? In other words, they're the ultimate consumer in terms of health care. And the reason they are is because it's fully connected to their pocket. And what we need is a model where we have a connection, not an absolute, but a connection of price and payment to be reinstituted. And that's what we've tried to do through the Seniors Choice Act. I get letters all the time from seniors about their health care and the waste associated with Medicare. I mean, hundreds of letters every month about what they're seeing. And of course, there is no connection to their pocket because Medicare is paying. They don't have a connection, and yet they know Medicare is in trouble. The final point I'd make is why we have to change Medicare is if you go back to the macroeconomics that are facing our country and the fact that we're going to add another $6 trillion to our debt, and that Medicare after PPACA has increased its unfunded liabilities by $15 trillion. That's what the increase was through PPACA in terms of increased funding, liability. We have to fix Medicare. And it's not a choice about the status quo, which is what the typical politician says is, oh, we're going to protect Medicare. What we ought to be saying is we're going to make sure you have quality health care. But the system we have today isn't working, is highly inefficient, and will bankrupt your children. And so the choice isn't of Medicare as it is today and nobody's going to touch it. The choice is how do we fix it where our children can in fact afford it. Number two is how do we make it better? How do we give more security for that aging American so that they know that they're not going to be bankrupted, that their lifestyle is not going to be markedly changed through any changes that we would make in Medicare? And we can absolutely assure American seniors that we can do it better, we can do it more efficiently, and they can have the security that they have today. But knowing that that security does not come by a loss of standard of living of their children and their grandchildren. So with that, I'd be happy to take any questions and go into details on the bill and visit with you on it. Yes, sir.
I'm sorry, can you wait for the mic, please? And also, please identify yourself and your organization.
Thanks. Okay, my name is Thomas Cloud. I'm a reporter with cnsnews.com. My question is, you mentioned market forces and consumer choice as being the key to solving Medicare. And if that's the case, why not simply just phase it out and replace it with just kind of a cash subsidy directly to the person and let them choose among whatever with the cash.
Well, it's not cash. It's a premium support, which is a payment and allows them to use it. So in fact, if I'm 65 years old or 66, 10 years from now, when I'm Medicare age, I will get a deposit into a health account of a fixed amount. And if I buy something that covers and meets my need that is less than that premium support, I pocket the difference. In other words, it's essentially what we're doing. What we're saying is you can take that same thing and buy traditional fee-for-service Medicare, or you can buy any plan out there that meets your need. So we're essentially saying that, but it's still, you have the guarantee of having the ability to buy that every year. So we don't allow that's why the committee that we've set up to oversee this, make sure that we don't get cherry picking, that you don't get caught with an illness that you can't insure. So what we're essentially doing is what you suggest, but still allowing seniors who don't want to go there, who say, I don't want to have to make a choice about what's best for me. I want to stay in fee-for-service Medicare. So you can do both. You can stay in fee-for-service, but fee-for-service will have to be competitive with the average costs of those plans. So what it does, it not only causes the insurance industry to have to compete for these dollars, but it causes Medicare to have to be actuarially equivalent in terms of the cost and the benefit. Again, remember, $1 out of $3 in Medicare isn't helping anybody. And what we're trying to do is squeeze that $1 out of $3 where it's 1 in 20 or 1 in 25 out. So essentially, and if you want to buy something better than that, if you're well-to-do and you say, hey, I want to buy something better than this, you can buy something better than that. But you'll never get less benefit than what you're getting today in terms of the benefits you receive, in terms of access to care. See, the problem where we're going with Medicare today is the system we have set up is a promise with no access. Ask somebody that's going on Medicare today how easy it is to find a new Medicare doctor. 40% of the physicians in this country aren't accepting new Medicare patients. And that's growing every year. Why is that? It's because Medicare isn't competitive. Or they're overly competitive in some areas and under-competitive, like the disruption and the maldistribution in terms of physician specialties versus primary care. So market forces would take care of that, whereas a controlled elite system run by Washington doesn't take care of it. Sure.
Hi, I'm Arnold Kling. If you're 50 years old today, then if you say you're going to get the Medicare benefits of a 65-year-old today, let's say 25 years from now, if you extrapolate the trends in healthcare, that might feel like, if people really understood that, they might say that's really actually insufficient, or it's a lot less than what Medicare is promising me now. That is, Medicare is promising me at 75, I'm going to get, as healthcare spending rises relative to everything else, that I'm going to get a much bigger share. So doesn't that mean that at some point people have to be told that they need to save more to be, if they want to spend anything like the share of spending on healthcare that's expected 25 years from now?
Well, I think that's a great question. I think that discounts the fact that $1 in $3 doesn't help anybody. And can we use market forces to make it more efficient so that that incremental increase in cost isn't there? Ask yourself, why are healthcare costs rising? Is it all technology? What is it that's forget the demographic numbers, the increased numbers of seniors. Let's just say that the number of seniors is going to stay constant. Why is it rising? It's rising because there's no competitive forces and there's no connection with overutilization. The age-old joke is, as physicians, is why do people come see you? They come to see you so they can, it's cooler in my office in the summertime than anywhere else in town, and it doesn't cost anything to come in to see you. Okay, now that's an extreme example, and I don't mean to say that that applies, but the point is if you have market forces and if you have a need, we're not promising a Medicare that's like today, tomorrow. What we're promising is quality health care that is affordable for you, that is not rationed from Washington, that both you and your children can afford. And we're also saying is if you're 50 today, you probably are going to, if you're 50 today, you're probably not going to receive Medicare till you're 66 or 67 because we have a slow incremental increase in the age of eligibility associated with that. But the point being is, can you allocate a resource better than we're doing it today? And, you know, there isn't a study out there that says we're allocating resources very well. Matter of fact, every study says we're allocating them terribly. Let me give you an example. The new healthcare law mandates physicians will use IT, right? I mean, we're giving every doctor in the country $50,000 to buy a computer system. I mean, that's essentially what we've taken your tax dollars, the people who average $250,000 a year, and we're taking $50,000 of your money and giving it to every doctor in the country. Here's what the first exam of what has shown on utilization of IT. The doctors who now can get their tests through a computer in terms of diagnostic x-ray tests, whether MRI, CT, x-rays, whatever it is, who can get that through the aid of IT, order 14 to 18% more tests than doctors who don't. So if something's easy to utilize, guess what happens? It gets utilized. And so what we know is all these supposed benefits on IT aren't going to drive any efficiency. They're going to make us have a more compact medical record that nobody looks at. If you talk to doctors in terms of a computerized model now who are using it, because it's got so many spots to fill in, they don't look at it. They put a little note at the bottom of it and said, here's what I did. So now we're playing the game on IT, but we're not going to utilize it, and it's not going to save us significant money. It will save us information money on when somebody doesn't have something over here and you need it, you can go get it. But right now, the first test out of that is it causes increased utilization rather than decreased utilization, with no change in outcome for the patient.
Senator, we have a first question in from Twitter, and the hashtag, I will remind people, is Senior Choice hashtag. The question from Twitter is, do you think things might change if Mr. Santorum or Mr. Romney wins in November?
Well, I think some things will change. You mean on health care? I guess they're implying.
On this issue on Medicare.
Here's what I know as an accountant, a businessman, and a physician. We're on an unsustainable course. We can say, we can tell the political lie that don't worry about Medicare, nobody's going to touch it. And then we're going to reach a bump in the road where the international financiers are not going to loan us money to fix it. Most politicians are afraid to talk about Medicare. When I talk to seniors in Oklahoma and contrast their grandchildren with what they have today, most of them want to make sure that they do their part to make sure their grandchildren have a great future. And we can do both. Doing nothing on Medicare assures seniors they're going to have a terrible outcome in terms of Medicare. If you want to save Medicare, we have to fix it now. We can't wait 10 years to fix it. We can't wait till we're in the middle of the baby boom cost explosion in Medicare to fix it. Simply because nobody in the world will loan us enough money, nor will we be able to afford the interest cost off that money to be able to do it. So the question is not whether or not we're going to fix Medicare. The question is, are we going to fix it smartly and do it in a way that protects the quality of care of seniors? Or are we going to wait till the international financial community comes in like they have with Greece and said, you will do this, 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 and this, even though it may not be the best thing for the citizens of this country? That's the choice we face. So we ought to be reassuring seniors we can provide quality health care. But how we're doing it, with the tremendous waste in it and the inefficiencies in it and the top-down control in it, ought to go away. And we ought to do it smartly. And the way to do it, if you think about the two areas where America is really failing, we're failing in education. Why are we failing in education? We have no competitive forces any longer that have any impact at all in terms of quality of education. The government's involved in an area, so we've taken competitive forces. What's happened in healthcare? The vast majority of competitive forces have been taken out. And so consequently, we don't get a response for efficiency and good allocation of a scarce resource. We just overutilize it, and we consume it inefficiently. Right here up front.
I respect your point of view, but the concern that I have is, how would you guarantee that the folks you labeled the government elites won't be replaced by free market elites?
Well, the free market, I guess the only way that could happen is if you didn't have this board that would say, I'm taking away your possibility. And that's why we put this oversight board in terms of what's being offered. But again, I would tell you, is that you can still have Medicare. You can have it just like it is today, but it's got to be competitive. In other words, we got to drive efficiency in. I would tell you that market forces aren't perfect. I would agree with you, but they're a darn sight better than any government bureaucracy I've ever seen. I don't know one area of the federal government that is both efficient and effective, because the motivation is you're spending somebody else's money. And so you ask me what our experience is in the last 230 years in this country. My experience tells me that we have done much better when we've trusted markets than when we've trusted elites. And where's the virtue of the elites? Do you really trust their virtue rather than yours and the market forces? Why is the average home in the United States 800 square feet larger than anywhere else in the world? Why is the standard of living and the wealth of this country higher than anywhere else in the world? How'd that happen? Did that happen through government elites managing a part of our economy? Or did it happen through market forces that allocated scarce resources and people actually making choices that were best for them rather than what was dictated to them by a government board? When you can't get, if IPAB continues where it's going and you can't get the services you want, or when the Preventative Services Task Force says, I'm sorry, you're now 75 years of age, we're not going to do a mammogram on you and diagnose your breast cancer because it's not cost effective in terms of the value of your life. If you want a government bureaucrat to decide that for you, I'd say you should absolutely oppose what I'm saying. I trust American people more than I trust American institutions. And I think American people will look out for them and theirs better than any bureaucratic organization can.
Claudia Anderson, The Weekly Standard. I'd like to understand better how this financial incentive works. You say the premium support goes into an account for the individual, and say the individual has a good health year and there's something left at the end of the year, then that stays in the account, and then the next year they get a new premium support?
It doesn't even have to stay in the account. If you're a senior and you've bought a health insurance policy for your Medicare and it costs less, you can do with it what you want. The point is, the whole point for this advisory committee is to not allow the games that are played in insurance to cherry pick or undermine your health condition, so that we create a real competitive model. That does two things. One is it guarantees you coverage. Number two is it drives towards prevention. Now, what do we know? What do we know? That still in this country, the first symptom of the vast majority of people with heart disease is what? Death. Why should that be? Why is that? Well, it's a preventable disease. It's a diagnosable disease. So why is it that half the people whose first symptom of heart disease as they drop over dead. So what we want to do is both drive prevention and the management of chronic disease. We don't have health care in this country. We have disease care. And what we ought to be doing is how do we revert that back to health care where we prevent disease or manage disease effectively. So if you have 20 different companies competing for your business and they know you're going to still be there, then what we want them to do is we want them to invest based on their own profitability in your prevention of a major disease.
We have some more Twitter questions. One is for you as a doctor, sir. How do you think treatment changes or differs as a result of Medicare and government dictates?
How do I think it changes? Well, the first thing I think it changes based on Medicare is doctors have no concern right now for what anything costs. There's no penalty for physician ordering tests that aren't necessary. Tell me what it is. If I have a patient that comes into my office that's referred to me that saw a doctor 4 days ago and they did blood work, and I look and say, well, I can get the blood work back right now, or I can spend an hour with my nurse trying to find online that first of all, I got to meet HIPAA requirements. So, I got to get everything signed so that I can have your information, because I might accidentally disclose it, and they can't trust that I can call them and this is Dr. Coburn, will you tell me these results? Because HIPAA doesn't allow that anymore, because they can't know it's Dr. Coburn. How do I do what I need to do that's both efficient and effective? What drives me to do that? Blue Cross Blue Shield knows my profile as well as every other insurer in Oklahoma. They know whether I'm an efficient physician. They know whether I order excess tests. They actually have a profile. Every insurance company in this country knows everything about every doctor's purchasing habits. They actually measure each doctor by what it costs them to care for the identical diagnosis. One of the things that's happening to Medicare patients, because doctors are opting out, the people who are not opting out of Medicare are not the best physicians. The ones that are opting out are the ones that don't need Medicare patients. So market forces should reward doctors who are efficient and get there. Well, who knows that? Medicare knows it too, but it's anybody that wants to, as long as you qualify for Medicare, you're going to get paid. So there's no market force on the quality of physician, but there is. If I'm way outside for Blue Cross Blue Shield, you know what happens next year? They don't want me. They don't want to allow their patients to come see me because I'm not an efficient or effective doctor. That's one of the things that is really positive. I'll have another story. I don't have time to go into it, but just suffice it to say, we resisted an insurance company who offered us a contract, my former partners and I, for caring for a large number of people who worked in industrial plants in my hometown. We told them no, it wasn't enough money. And we said, go find out whether or not you think we're efficient. Well, ultimately, they came back and offered to pay us 20% more than they were paying anybody else in town because we were about 30% more efficient than the rest of the doctors in town in this one large group. So what they did is they looked at the data, and what they found is they want to have physicians that are efficient, that don't over-order tests. We don't have any of that mechanism going on in senior health care because there's no penalty if I over-order tests. And you can't develop a bureaucracy big enough to micromanage that. You'll never do it. You'll spend more money on the bureaucracy, just like we do at CMS today.
I'm Kerry Weems. Senator, we know that a disproportionate share of Medicare expenditures go to those in the last, several months of life. Given the fact that that fee-for-service would remain an option, would you see, first of all, people perceiving themselves better off who are in that condition in fee-for-service, and if so, doesn't that leave a significant financial exposure in the Medicare system?
Well, in other words, the assumption, Kerry, is that as they get older, they're going to get out of the insurance and back into that. I think that there may be some of that. But again, the biggest problem we have with seniors today, part of it is we have two big problems at the end of life. One is the threat of lawsuits. You can have an advance directive and a living will, and I've been in this situation a number of times. I've taken care of a patient for 20 years. They come in with a late term event or the hospitalization prior to their late term event, but we're getting towards the end of life. And they have an event that's happening, and I'm wanting to follow their advance directive. And a grandchild or a niece comes in and says, "You're going to do everything." And I thought, and this has actually happened to me. I said, "No, I'm not. I've had a great conversation with your aunt. I've known her for 20 years. I'm not about to do harm to your aunt." "Well, I'm going to sue you." And I said, "Well, what you need to do is just fire me as her doctor, because I don't care whether you're going to sue me or not. Now, I'm going to do what she wanted." The fact is most doctors won't stand up to that. They hear the word lawsuit and start running. The other thing that I would tell you is, why is it that if in fact in that advanced case, there's no connection at end of life with the cost? The key thing I would tell you that's different about our proposal is that Medicare has to stay competitive. So we're mandating that whatever this average cost is over here, that's where Medicare has to be. And so what we will do is drive it towards that. In other words, you as a patient can't cherry pick the program, because the program's going to have to stay competitive with the private market.
We have another Twitter question. This is from Joshua Booth, and again, the hashtag is hashtag Seniors Choice, hashtag Seniors Choice. The question, and I think you'll find this one interesting, is Joshua thinks that your plan sounds like the Affordable Care Act. Exchanges, subsidies, market forces. Is this just extending the individual market rules of the Affordable Care Act to Medicare?
I don't know hardly any market forces that are working in the Affordable Care Act. That's number one. There's no true exchange. What we're doing is let a real market out there. All we're saying is we're going to make sure whoever's participating in that market isn't cheating seniors, both in terms of quality or actuarially equivalent program. That's all we're doing. So I feel greatly insulted that is compared to similar to the Affordable Care Act.
My name is Blair Forlaw. I'm an economic development consultant here in Washington and also a member of the No Labels Citizens Movement. Really appreciate your remarks, Senator, and your emphasis on the importance of the budget, informed decision-making, choice, accountability, and the importance of a robust representative government. And I think those of us in No Labels feel particularly that not only are some of our systems broken, as you've alluded to some of the problems with Medicare, but Congress is broken now too, and not really. We wish that members of Congress were all about the importance of the budget, informed decision-making, accountability, and representative government. And I wonder if you could share with us your thoughts. You've seen how sausage is made there on Capitol Hill, and we, the taxpayers, certainly have some skin in the game, not only on what happens to Medicare, but many other important issues. What can we do and that could help fix Congress so that some of these same principles you've talked about today can be a part of the decision-making process underway, and so that thoughtful proposals such as the one you've described can be honestly considered and debated?
Well, that's a good and tough question, and it's going to get me in trouble, and I don't mind being in trouble with my peers. I think the first thing you can do is quit sending career politicians to Washington. We have the government we have because American people have sent the people that are here. And they're wonderful people. They have great hearts. The fact is most of them lack a frame of reference about what the real world's like. When you take somebody that has never had real exposure in the real world on real issues that required blood, sweat, and tears, and hard knocks, and you have people without that who have been in a political position the whole time, they're working at a deficit. And the deficit is the real world and common sense. And so if you look at the Senate, 65 to 70% of the Senate is filled with people are opposite, the exact opposite of a guy by the name of Ron Johnson. Ron Johnson had no political experience whatsoever. And what's his number one thing? Fixing our problems. He didn't care about the politics. Matter of fact, there's more conflict on our side of the aisle with guys that want to fix the problem rather than care about the politics. The second point I'd say is that hurts decision making in Washington is everybody's always thinking about the next election, which means they really like the job. And what we need is people who hate the job, like I do, but want to fix the problem. And so what I would say is if you want to fix Washington, you can do process reform and it'll make some impact, but it's not going to change till you change the motivation of the people that are here. And it's always the horizon is the next election. We will fix it after the next election when we're more secure. And that just goes back to human nature. It's kind of like a senior buying Medicare. Is everybody wants to get stroked. Politicians' stroke is getting reelected. I think what we should do is fix, we have the capability to fix every problem in front of this nation right now. That capability is there. The problem is if we fix it, we'll all get fired. Great, let's fix it and all go home. Mm-hmm. The point is most people don't want to go home. I can't wait to get home. I would tell you is you have the Congress you've sent here because you have, as Americans, have decided you're going to put your vote and your vote with career politicians who tell a big story, but the action, they're great salesmen, but their action is far different than what you've been sold. Ask yourself the question. There's a bipartisan bill, I think 37 co-sponsors, called the FAST Act, which will address tons of the fraud that's occurring today in Medicare. Why, bipartisan support in the House and the Senate, that we worked with CMS to develop this bill. Why isn't it on the floor and passed and sent to the president? It has nothing to do with Medicare. It has everything to do with the next election. And there's hundreds of things like that. There's 27 different job bills waiting that have passed the House that aren't going to come to the Senate floor. Not because the country doesn't need them, because it doesn't fit with the scenario of the next election. So what is the motivation is we ought to be Americans first and Republicans and Democrats and independents second, and you see exactly the opposite of it. And that's what we can change all the process we want until you change who's coming up here and what their motivation is in terms of being here and getting the stroke. You're not going to change it. Next question.
Dr. Coburn, I very much appreciate the idea that market forces and consumer choice can really control our healthcare costs and improve the system. But I worry that it doesn't operate like a true market, not just because of government involvement, but because of the imbalance in information between consumers and insurance companies primarily, but also consumers and their actual care. I'm wondering if you've considered in the Seniors Choice Act supports and tools to help seniors understand what they're choosing when they choose their health plan. Not just the monthly premium, which is probably the clearest thing on your paperwork, but also the kind of benefits you're receiving, the kind of care coordination and other supports you're receiving, and the kind of out-of-pocket costs you're exposing yourself to.
I think that's a great statement and a question. We have looked at that. That's part of what this this organization is going to be that's going to control this. We have it right now. We have 15 supplemental plans of Medicare. We tell them what you can put out, what you have to put out. It's not any different than that, the same thing. The question is can seniors navigate that? And up to a point, yeah. But I would tell you that my mother died a year and a half ago, and my brother and I helped her navigate what the choices were when she no longer could do that. So we're talking about a very small group of people that are not going to have family involved in helping make those choices. The question is how do you keep the bad actors out? And how do you keep those that want to cheat in the system, and how do you have enough transparency so you know when that's going on, so seniors aren't being taken advantage of. That's the key. But I'd go back to the other point, is one of the reasons our health care is out of control is everybody thinks somebody else is paying the bill. And I'm the first to admit that market forces won't solve everything, but I'll guarantee you they'll solve it a whole lot better than what we're doing today. And there will be people that fall through the crack. It won't be perfect, but the allocation of that resource to actually apply dollars to make somebody have a good health outcome is going to be much better than what we're doing today, because there will be a consequence for a doctor overutilizing something, because they'll be being watched by the very people they're contracted with in a private insurance that's competing in Medicare, that they're not going to do it inappropriately. And we have, there's no controls, there's no brakes on this system now for bad behavior in terms of the market. And what we have to have is, the question is can we have great health care for seniors and have it in a way that's much more affordable than what it's going to be in the future? And I think the answer to that is yes. And that doesn't mean we trust markets 100%. That means we let markets work, but we make sure we have the controls. But when market starts, if we have a bad actor in that it's identified and they're gone.
Senator, we have time for one last question from the audience, and then one last Twitter question,
Okay,
depending
right
on the
up
answer.
You said many times that a big factor is control, finding the physicians that overutilize as a criteria. What are you going to do to protect against the ones who are going to underutilize testing and that sort of thing, just so they appear good and score high?
Well, first of all, I think that there are two different aspects to your question. One is laziness. The other is whether or not you have a physician that's committed to your health care. And I'll tell you, if you have a physician that's not committed to your health care, doesn't matter what system we have, you're gonna lose on that. I can't see a guy, if you come to me as a physician, if I'm really a physician, and I'm not talking about being a doctor, I'm talking about being a physician, which is what we should want, and I'm gonna cut a corner on your health care so I look good, I've already violated my Hippocratic oath. The difference is I can look good and somebody else pay the bill when I overutilize. But you're talking, and that's the whole point of where we're going right now. Guaranteed Medicare is not guaranteed quality care and is not guaranteed access. And the choice is are you going to have access to a doctor in the future? That's the first thing. We're going to have 150,000 shortage of doctors in the next 10 years in this country. The doctors my age are all say, see ya, I'm not messing with this anymore. I've had it. So I would say the motivations on both sides of that question are different. Could that happen? Absolutely. That happens today. That happens because when you go to see a doctor, on average, they don't spend the time they should be spending with you to actually listen to you about what's going on with your health care. That's happening today because Medicare underpays primary care doctors. And so what do? Rather than sit down and spend 45 minutes with you to hear what's really going on and get paid for that, which Medicare won't pay them for, they spend, you go in, the average right now is less than 30 seconds before they interrupt you with you telling them, so because they got to get busy to see the next patient. So what do? They hear part of what you say, they order a whole bunch of tests to cover themselves and walk to the next room because they're on the treadmill because Medicare has set up a payment system that says you can't make it if you actually spend the time with the patient. We won't reimburse you for doing that. And there's good studies coming. We have this new group of doctors out there that have said, I quit it all. I'm going to go into concierge medicine. You pay me a flat fee. I'm yours 24/7, 365 days. You get a comprehensive exam. I'll see you, talk to you anytime you want. These doctors are telling us this. I'm finally getting practice medicine the way I was trained. I get to sit down and listen to my patients. On average, they're ordering 40% less tests because they're actually listening to the patient. The insurance companies that are actually covering some of these are actually spending less and getting better outcomes, reduced hospitalization, because we were all trained. No matter what you do, listen to the patient. They will tell you what is wrong with them. And nobody's listening because we have a system that said, get in the treadmill, here's all we're paying you, here's all Medicare's going to pay. I can't pay my nurses if I do practice medicine the way I want and get reimbursed for Medicare. That's why you're seeing people not want to take new Medicare. So what good's a Medicare program if you can't get a physician? And if you can get one, what good is it if they won't listen to you? So I would tell you the downside is continuing the status quo because it's going to get worse. And we know that. I mean, we're seeing it.
Well, Senator, I'm afraid that's all the time we have for questions today, but on the behalf of the Hudson Institute, I'd like to thank you for coming here today, for your leadership on these important issues, and also wish you a happy 64th birthday yesterday.
Thank you. See y'all.